Well, welcome to the latest No5 Clinical Negligence Group vlog, where we're going to consider what does the COVID pandemic mean for the standard of care. It would probably help if you take a moment to read the article for AVMA that Neil and I wrote, which considered the cases of FB and Mulholland. And whilst we're going to kick around various COVID and non-COVID and maybe GP and other treatment delay situations, we're really just posing the questions rather than giving the answers. So none of this should be taken as legal advice. So Neil, as an ex-medic turned lawyer, you were redeployed to the medical coalface during the pandemic. How was that?
Chris, well, it was a really interesting experience, and I predicate my responses on both my first-hand experiences, but also speaking to colleagues working in a variety of NHS trusts. And I think we've all recognised the past 12 months or so has been tremendously challenging for the NHS.
Yeah.
And that's been compounded by what is already an overstretched organisation. But what we really saw, particularly with the first wave of the COVID outbreak, was that it wasn't just the influx of patients, but it was also, of course, staff getting sick, and that put extra stress on resources and personnel. And that required the redeployment and reinforcement, both through asking retired clinicians and nurses to come back, speeding up final year medical students through their studies so that they had a shortened final year so that they could start working, but also redeploying staff from their normal working environments into environments in which perhaps they hadn't practiced in for many years. And
was there an initial period when there was less redeployment because staff weren't sick? So in March, April, and then we've got to get more bodies in after that, or how did it work?
No, absolutely. So there was the initial uptick in patients coming in, but at that stage there was still capacity and flex within the system that allowed them to compensate for that. But then it hit the critical mass, and it was this perfect storm scenario where staff were going off either because they had symptoms themselves or they were having to self-isolate because family members had symptoms. Yeah. That takes them out of the work environment and workforce for 2 weeks. Potentially, and then you've got the build-up of cases coming into the wards, but also ITU, and the nature of COVID meant that the throughput was slow. So once they're starting to fill up, it takes a long time for patients to move to the next phase of their recovery. So it was the combined effect. So it was really by May that it hit that critical marker.
So when retired medics are coming in, when medical students are coming in and non-ITU specialists, how are they deployed? How were they allocated?
So it depended on their experience and their roles, but primarily more junior members of staff were redeployed to ITU. There was then situations where perhaps the elective work started slowing down and then it eventually stopped. And certainly surgical specialties much of their work was put on a pause, and there was re-rolling of their wards. So you ended up with a plastic surgery ward becoming a hot COVID ward where COVID patients would come, and you'd have the plastic surgery team doing the day-to-day care of those patients with oversight from a physician.
So if I understand that, you've got junior ITU staff acting up within ITU, then you've got non-specialists, plastic surgeons on respiratory wards under the supervision of respiratory clinicians. Is that right?
To a degree, but then you've also got non-ITU specialists coming in to fill the gaps in the ITU rota. So they're having to learn those skills about ventilators and intubation. And
on the hoof. Actually learning on the job.
On the job. And we ended up in scenarios where you've got consultant surgeons being part of the proning team on ITU because they're not operating, the elective care is gone. And so they're being involved in that side of care and taking on effectively nursing roles. The other factor, of course, was that you've got nurses who would typically in ITU be doing one-to-one care, in HDU maybe 2-to-1 care. ending up looking after 4 patients or more on their own. And so it was a completely different dynamic, and probably the closest you could get in a civilian setting to that battlefield type mentality of firefighting as we went along.
So
Neil,
go ahead.
in that environment, Neil, where you've got a plastic surgeon being supervised by, say, a consultant respiratory expert, where would the buck stop if something went wrong? Would that be the consultant physician, or would it be the plastic surgeon?
It's a difficult mix, because ultimately the ward was being run on a day-to-day basis by, say, the plastics team. But the respiratory clinician would be available on a remote basis unless they needed to come onto the ward, unless there was a specific reason to come onto the ward. So much of the day-to-day management had been effectively seconded to the plastics team in that scenario. And to add to the complexity, because of the demand on ITU beds, because of this the slow rate of throughput, patients who would traditionally have fulfilled the criteria for HDU and ITU were having to be managed on the ward. So they were genuinely looking after some pretty sick patients in an environment where perhaps they hadn't done medical specialties opposed to surgical specialties for many years. And
was there a sense in which, when juniors are acting up or people are being trained on the job or outside their specialty, was there a sense of people saying, I'm out of my comfort zone, what the hell's going on here? Who's going to back me up? Was there discussion of sort of immunity from suit? Are we going to get sued here, and who's going to have our backs? Was there that sort of discussion?
I think people were genuinely concerned, because it's human nature. We feel comfortable in environments in which we have built up years of experience, and when you're thrown into an environment where you're lesser, and medicines, you start off with a very wide base of knowledge, and then you focus it down as you specialize, and you become innately ingrained in that area, but by definition you lose some of the knowledge in peripheral areas that don't affect your practice. So people were genuinely concerned on what would happen, where the buck would stop, and what the culpability was. I know that there was a lot of appreciation from Claire Marks, who's the chairman of the GMC, when she came out and noted that it was acknowledged we will all be pushing to the extent of our comfort zone, and in many cases beyond that. And it was felt that the GMC would be keeping our back on this occasion if disciplinary issues arose out of it, because of people being stretched, because this was unprecedented. But it doesn't remove the fact that allegations of negligence are likely to arise out of care, and that does weigh upon clinicians.
And I mean, obviously, there's Section 11 of the Coronavirus Act 2020, which gives indemnity but not immunity. Was there a? I mean, the GMC called for immunity from suit. Was that something that was talked about, or were people just desperately trying to get on with the job?
I think in down moments it was discussed, and there was appreciation that both the GMC and the defence unions raised the issue. I think that there was frustration that the legislation perhaps didn't go further, because there was a sense of, we're doing the best we can. We just want that security that if something goes wrong, there will be an understanding of the pressures that we've been operating under. But it got to a tipping point where, frankly, you were going in, you were doing your job, and you were so knackered at the end of the day that conversations about what might happen in 6 months or 12 months' time went on the back burner.
Yeah. So John, what's your take upon how the law should judge the standard of care in these situations of acting up and redeployment and people out of their comfort zone? What's your view of it?
But I suppose the question is, if an orthopedic consultant or a plastic surgery SHO or a psychiatry registrar is redeployed to ITU, should they be held to the standards attaching to an ITU specialist?
Yeah.
In ordinary times, the law has a very clear answer to that, and the answer is yes.
Yeah.
Ever since Wiltshire, 1970s, probably before that, it's been well understood that there is a single standard of care attaching to the act rather than the actor, permitting uniformity across all of the categories of duty of care. Think Nettleship and Western for driving, think all brands and flavours of professional negligence. And departures from
so
that.
by the act, you mean the clinical action rather than who's performing it? Is that...
Yeah, the language usually adopted in the authorities is the medical task. So it is that specific.
Yeah.
And departures from that single standard related to the act tend to be reserved very rare occasions for movement upwards from the standard. If you are promised some superior standard of care, then the law will hold you to that, usually by contract, but occasionally in tort. There have been attempts by defendants to argue for special treatment or different treatment for rank for junior doctors. Courts have generally shied away from that argument. One example is the 2017 case of FB and Rana, where the Court of Appeal overturned a finding below that whilst it would have been negligent for a consultant to fail to elicit some piece of history in the A&E department, it was reasonable for a junior doctor to have failed to have done so, and the Court of Appeal said no, single standard applies. But as I say, that's the answer in ordinary days, and these are not ordinary days, as we all know. And when you go back to Wiltshire, touching on something Neil mentioned a few moments ago, Lord Justice Mustall, in laying down single standard, made an express exception for battle conditions. And the example he gave was when an emergency overburdens available resources and an individual is forced by circumstances to do too many things at once, the fact that he does one of them incorrectly should not likely be taken as negligence. And it can't really be contested, can it? That this is an emergency that has come close to overburdening available resources, indeed would have done, were it not for redeployment. So he doesn't say immunity, and the Coronavirus Act doesn't say immunity. And there's never been a trend, has there, of successfully defending a case because the doctor, was too busy or I was momentarily distracted. But there are examples of the law shaping the content of the duty to the circumstances on the ground. We all have experience of cases of decisions taken in the agony of the moment, in a birthing suite, in an accident and emergency department. The case of Mulholland from 2010 expressly says so. You must take into account the realities of operating in a busy, pressurized environment. And here we are today. Those circumstances will be taken into account.
Yeah, but it's interesting, isn't it? That, I mean, you mentioned A&E and obstetric. That in Darnley and Croydon Health Services, so the obviously that great and famous victory, lost at first instance, lost in the Court of Appeal and up to the Supreme Court. So the negligent A&E receptionist, who inexplicably, no real explanation, told the head injured claimant that he'd have to wait 4 to 5 hours before somebody looked at him, rather than he'd be triaged within 30 minutes. But the Supreme Court touched upon the pressured environment of a busy A&E department. They touched upon the pressures on resources, but effectively affirmed Wiltshire in saying that, well, a duty of care is a duty of care, and once you've received the patient into that healthcare relationship, that pathway, as it were, whoever a trust charges with delivering that care, the legitimate expectation of the patient is that they'll receive the degree of skill appropriate, as you said, to the task undertaken. So no one's suggesting that they should be seen in 2 hours rather than 4 to 5 hours. It's just that they have to have the basic skill set, the proper information. And there's also, you mentioned obstetric, there's a case of Douse, D-O-U-S-E, and we'll put these in the links. Very sad case, serious hypoxic ischemic brain injury caused to a baby, where very difficult and unsuccessful 16-minute cesarean section, obstetric registrar, when the consultant arrived and notwithstanding the difficulty, completed the cesarean section in a couple of minutes. And the court in that case, notwithstanding the pressure, reaffirmed FB and said, well, the registrar was acting up and the standard is derived from the role being undertaken. So issues of pressured environment, resources, they again seems to be affirming Wiltshire, affirming FB, doesn't it?
And I think there's been a narrow and a rightly narrow construction for battle conditions up until this point. But just thinking about the narrow question, the redeployed in ITU, given that is all pretty agony of the moment decision making, and given that the people in those beds are already terrifically ill, it's going to be have to be a pretty gross departure, I think, from the norm to get over the battle hurdle condition in there. I think as you go wider and we look at the wider effects of COVID on the NHS generally and on medical provision generally, battle conditions will dissipate back to the pre-COVID norm. Yeah,
and let alone issues of causation, sadly, for desperately ill ITU patients. Neil, what's your take on the sort of non-battle conditions, the non-ITU patients in COVID, in that sense?
I mean, in many ways, I'd say there remained battle conditions even within the wards, because I alluded to it earlier, because of the capacity issues with ITU, and the unit I worked in, in normal circumstances, it has 100-bed ITU, and they opened up 2 further wards to meet demand. But because of the pressure on it, you were having patients who would traditionally at least be at HDU level care being managed on the ward. So that is out with the comfort level of most clinicians working in that environment, particularly if they've been redeployed into a medical specialty from another specialty. So I talked about plastic surgeons, but you could easily have a dermatologist who is being asked to do general medical work. And therefore you're creating, although at a lower level, still battle environment in which people have to operate. And I'd throw one more thing into the mix. In the hot COVID wards, you're doing all of this in pretty uncomfortable, pretty hot, pretty restrictive PPE equipment. And you're making difficult decisions when, and you add in all those external factors, and that puts a huge pressure on the clinicians involved. And you can see how errors can seep in what is otherwise well-intentioned practice.
Yeah. Gemma, what's your take? I think you were mentioning earlier about the sort of GP non-COVID patients. I think you've got some knowledge about obs and gynae care and situations and so on. What's your take on that?
Yeah, I think the issue that we've all seen sort of firsthand for GP surgeries and the like is they themselves are dealing with a balance between not exposing their patients and their staff to the risk of acquiring COVID, whilst also making sure that they can provide appropriate care to their patients. And there's a number of standard operating procedures that the NHS have put out and the Royal Colleges have put out. And the emphasis, I think, is on the triage system. Most GPs are encouraged to introduce a telephone triage in the first instance to then decide whether patients should go and have a telephone consultation, a video consultation, or a face-to-face consultation. And it strikes me that is going to be where a degree of focus falls, and it touches on all of the cases we've been looking at. The Darnley case, is the receptionist giving the right information? The Pope case, what questions are being asked by the practitioners over the telephone or by video consultations?
The Pope case was the swine flu. I think Neil and I mentioned it in the article, the swine flu case where the experienced nurse didn't follow the guidelines in the H1N1 guidelines in questions, I think, wasn't it?
That's exactly it. So they didn't ask the right questions to understand whether or not it was in fact swine flu, and that I think the person was sent home, and that was found to be a breach of duty.
Yeah.
But there's also going to be, I think, a degree of the sort of Mulholland, if you like, realities of the environment. So the quality of the consultation, if done by telephone or by video, is obviously not going to be as good as if it's face to face.
Yeah.
So I suspect there's going to be missed opportunities to make diagnoses and make referrals. And I think a question that the courts will invariably be asked to deal with in due course is, what was the standard of the reasonable GP conducting a video consultation? And is that going to be a lower standard than if it was a face-to-face consultation?
Yeah, I suppose they might. The first issue maybe, was it reasonable to conduct this consultation remotely, and then make a decision about that, and then, if it was, then, as you say, judge it by a slightly different Mulholland type, reflecting the reality of a remote consultation. I suppose that's what you're thinking of, really?
That seems to be the issue for me, and what is the threshold for having a face-to-face consultation, and will that have changed over the course of the past year? We know that last summer things were a lot more relaxed from a sort of COVID secure perspective, when the rates of infection were a lot lower. Does that mean that there's a lower threshold for having face-to-face consultations again? These are all, I dare say, questions that be resolved over time. And then there's things like referrals for cancer. The standard 2-week wait still is in place. The 62-day sort of diagnosis to treatment target is still there. But there are, again, guidance issued by the NHS to say that first 2-week wait referral can now be by telephone. And then where there has been an urgent referral made by a primary care practitioner, there can be, by consent, an agreement between the primary care referrer and the referring authority to downgrade that from being urgent to something else. Really? Which again, I suspect is going to give rise to some difficulties further down the line. Then in things like obs and gynae, I know sort of anecdotally from friends who work in those wards, the amount of time that mothers are spending on labour wards has reduced down to hours from days. So are all of the necessary observations being undertaken? Are things being missed simply by the completely understandable desire for both patients to go home straight away out of that environment, and for beds to be freed up? All questions I'm sure that we'll have to look at further down the line.
And is there a sense from on the obstetric ward that women are being discharged, protectively, so they're not exposed to the risk of COVID, or a sort of knee-jerk, get them out, we need the beds? I mean, what's the sense there?
I think it depends on the locality. So some units have sort of clean wards, as they put it, and COVID wards. So the idea was that everybody is tested before they come in. If they don't have COVID, then I think they're put onto the ward where they can spend a little bit more time. If they have COVID, they're obviously dealt with on the COVID side. But that then means that resources are sort of stretched thinner, particularly in the non-COVID wards. And I think there's been a real pressure in those wards to get people off, get people home again. And I think patients themselves, as I understand it, have been obviously keen to get home. Quite often they've not had their partners with them, and that's obviously been something that's been needed quite a bit. So mothers literally, 1 or 2 hours post delivery are discharging themselves.
Well, thanks everyone for that. So perhaps more questions than answers in relation to how claims arising directly or indirectly out of COVID-19 pandemic are likely to be considered by the courts. Perhaps it's an issue of how closely judges will adhere to judicial precedent in unprecedented times. Will it be a straight application of Wiltshire and FB, focusing on the act and the basic skill, the skill set, the task required, rather than the actor? Or as in Mulholland, will the courts want to calibrate the standard of care in a manner reflecting the reality of the pandemic? A fascinating issue. Let's perhaps come back in a year or so's time and kick things around again and see what's happened. So thanks to all of you, and thanks to everyone for joining us.
Thanks.